Welcome to this space dedicated to the dissemination of scientific knowledge, designed for specialists, general practitioners, and students, as well as the general public interested in health. In this edition, we present a detailed analysis of the study titled Asymptomatic True Gallbladder Duplication, a case report and review of the literature, a fundamental work for understanding the approach to this rare and complex congenital anomaly. This research was published in 2004 by Dr. Ernesto Roldan Valadez, in collaboration with a distinguished team from national reference institutions in Mexico. Throughout this video, we will explore how the team analyzed the clinical and radiological characteristics of this duplication, known as Vesica fellea duplex, which represents a significant diagnostic challenge due to its rarity, occurring in only 1 out of every 4,000 people. We will also identify key findings regarding the importance of preoperative diagnosis, the precision of imaging through ultrasonography and MRCP, and the relevance of the Boyden Classification to ensure surgical safety and prevent complications during future interventions. Legal disclaimer: this material is for educational and scientific dissemination purposes only. Its goal is to democratize access to the knowledge generated in specialized academic publications. Due to the dynamic nature of medical science, the information presented reflects the data available at the time of the original article's publication and may be subject to subsequent updates. Not medical advice. Under no circumstances does the information presented constitute a medical recommendation. The graphic resources used are only a representation of the article presented and are not completely accurate to human anatomy. For more information, you may pause the video.
Hello, and welcome to The Explainer. Today, we're diving into a genuinely fascinating medical case report from the journal Acta Radiologica. Whether you're a medical professional or just someone who loves a good scientific mystery, we're looking at an anatomical anomaly that is as rare as it is surprising. We'll be breaking down exactly how a completely hidden developmental quirk hiding right inside a patient's abdomen was discovered, mapped, and analyzed. It's a perfect example of how modern medicine handles the unexpected.
Okay, let's dive into this. Here is our agenda. First, an incidental medical discovery. Second, defining true gallbladder duplication. Third, the diagnostic imaging journey. Fourth, Boyden's anatomical classification. And finally, surgical risks and prevention.
Section 1. An incidental medical discovery. So we're looking at a completely hidden anomaly here. It wasn't found because of pain or illness. It was discovered entirely by accident. And to understand just how incredibly unique this is, consider this number. Based on autopsy series, the incidence of a duplicated gallbladder is about 1 in 4,000. It's literally a 1 in thousands chance, and statistically speaking, it pops up twice as often in women as it does in men. But as you'll see, our case today defies even those odds.
Let's look at the patient. We have a 44-year-old male with absolutely zero history of previous disease. He's taking no medications. When doctors did the physical examination, everything was normal. His hematological and liver function tests, totally normal. He was completely asymptomatic and was just admitted for a routine annual evaluation. And this really highlights the clinical stakes here, right? It goes to show how a major, complex congenital anomaly can basically hide in plain sight for decades without presenting a single symptom.
Section 2. Defining true gallbladder duplication.
Now, the medical literature is super specific about the terminology here. The formal term is Vesica fellea duplex. Basically, it's defined as a rare congenital anomaly consisting of 2 entirely separate gallbladder cavities, with each cavity possessing its very own cystic duct. This developmental quirk actually happens incredibly early in life, specifically during the 4th and 5th weeks of fetal development, arising from a complex of endodermal diverticuli.
And this brilliantly illustrates a crucial distinction. A true duplication involves 2 separate cavities and 2 distinct cystic ducts. We absolutely cannot confuse this with a bilobed or bifid gallbladder, which is medically known as Vesica fellea divasa. You see, a bilobed gallbladder is just a split or divided cavity that ultimately shares a single cystic duct. To be a true duplication, the whole ductal anatomy has to be entirely duplicated too.
Section 3. The diagnostic imaging journey.
So how exactly did the clinical team figure out what was happening inside a completely asymptomatic patient? Well, they progressively unveiled the anatomy in 3 distinct steps. Step 1 was a high-resolution ultrasound, which revealed 2 cystic structures. Suspecting a duplication, they quickly moved to Step 2, which involved administering a fatty meal. This tests the functional contraction of these structures and helps distinguish a working gallbladder sac from just a non-functional growth. And finally, to really map out the ductal structure, they utilize Step 3, the MRCP examination.
Now, if you're wondering, MRCP stands for Magnetic Resonance Cholangiopancreatography. It's a highly advanced, totally non-invasive imaging technique used to visualize the biliary and pancreatic ducts. While the initial ultrasound spotted the cavities themselves, it just doesn't give us enough anatomical detail about those delicate cystic ducts and how they relate to the broader biliary system. So the MRCP was absolutely essential here to get a definitive roadmap. And here is what that MRCP definitively revealed: a Y-type duplication. There were 2 separate gallbladder cavities, and an accessory gallbladder was found just inferior to the primary one. Each of these cavities had its own cystic duct, but those 2 separate ducts ultimately united into a single common duct, literally forming a Y shape. Both the pre-meal and post-meal scans completely confirmed this exact structure.
Section 4. Boyden's Anatomical Classification.
Now, what's really interesting about this slide is how it categorizes the anomaly. To understand why finding that Y shape was so important, doctors rely on an academic framework based on a famous study by Boyden. Look at the division into 2 main groups based purely on where the ducts go. In the split primordium group on the left, which is where our patient belongs, there's ultimately only one common entry point into the main bile duct, even though there are 2 cavities. Contrast that with the accessory gallbladder group on the right, where the cystic ducts remain completely separate and enter the system at totally different points. Pinpointing the exact group is absolutely critical for surgical planning.
Of course, arriving at that classification requires ruling out a whole list of imposters first. Through this rigorous imaging, doctors have to systematically eliminate conditions that mimic duplication. We're talking about anatomical folds like a Phrygian cap or a folded gallbladder, plus distinct growths like choledochal cysts, gallbladder diverticula, or focal adenomatosis. It's only when all of these are officially ruled out that a true duplication can be confirmed.
Section 5. Surgical Risks and Prevention.
So let's shift focus to the clinical stakes, because this isn't just anatomical trivia, it directly impacts real-world patient outcomes. Having 2 gallbladders drastically alters the risk landscape if things go wrong. Stone formation is for sure the most common issue, but patients can also face severe, escalating complications like acute or chronic cholecystitis, dangerous fistulas, torsion, where the organ literally twists on itself, and in severe cases, papilloma or carcinoma. If a duplicated gallbladder becomes diseased, the clinical picture gets very complicated very fast.
So, what's the game plan for a patient with a double gallbladder who feels perfectly fine? Well, the medical consensus is very clear. No intervention is required. Asymptomatic patients do not need immediate surgery. Surgical treatment is strictly indicated only when patients actually become symptomatic. But if symptoms like gallstones do pop up, the primary treatment is a laparoscopic cholecystectomy. And crucially, the surgeon must remove both gallbladders, not just the one that's acting up.
The conclusion of the case report really hits the nail on the head regarding these clinical stakes. Let me read this to you. Surgeons must fully understand the anatomic variations to avoid a second gallbladder perhaps being overlooked during surgery, leading to complications and the need for reoperation. The absolute biggest risk of missing this on an imaging scan is a catastrophic repeat surgery. If a surgeon goes in, removes one gallbladder, and misses a hidden accessory sac, that leftover sac can quickly become diseased and subject the patient to a whole second major operation.
Think about it. A major, true duplication hid perfectly inside a healthy 44-year-old man, only to be discovered by a routine ultrasound and brilliantly mapped by an MRCP. It really begs the question, with rare anomalies hiding quietly in asymptomatic patients all over the world, is our standard preoperative imaging doing enough to prevent catastrophic repeat surgeries? It absolutely highlights the life-saving value of rigorous, advanced medical imaging. Thanks for joining us for this explainer.
The reference for the article from which this information was extracted is displayed on the screen. Thank you very much for your attention and for joining us until the end of this analysis. If you found this review helpful, we invite you to share it with colleagues, residents, students, and anyone interested in these topics. Don't forget to subscribe and turn on notifications. This material is for educational and scientific dissemination purposes only.